Hi all, have a good day. We from the Department of OBG Sri Ramachandra Medical College, Porur, Chennai, presenting to you a case on breech presentation, and I am with the Safe Motherhood Committee of Foxy, and this is on request by the Foxy for absolutely educational purposes, and this case is being presented by Dr. Sharanya.
Dr. Pratima.
I'm Dr. Ashwin.
I'm Dr. Sadhana.
I'm Dr. Vignesh.
Presenting a case of breech delivery. Mrs. X, 28-year-old, G2P1L1 at 38 weeks, booked patient belonging to socio-economic class 2, has come from Porur for safe confinement, LMP 4/7/2018, EDD 10/4/2019, menstrual history 3/30 days, regular cycles, normal flow, marital history 4 years, no non-consanguineous marriage, no history of any contraceptive usage. Obstetric history G2P1L1, first pregnancy 2016, term normal vaginal delivery at Sri Ramachandra Medical College, female child, birth weight 2.9 kg, alive and healthy, present pregnancy, first trimester, spontaneous conception, confirmed by UPT at 45 days of amenorrhea, no history of fever with rash, UTI, drug intake, radiation exposure, taken folic acid tablets regularly, dating scan done and corresponding to dates, no history of excessive vomiting or spotting PV. Second trimester, third month NT scan was done and found to be normal, quickening felt at 5 months of amenorrhea, 2 doses of injection TT taken, 5th month scan was done and anomalies ruled out, no history of raised blood pressure, OGTT was done and found to be normal, iron and calcium tablets taken regularly. Third trimester, growth scan was done at 32 weeks and growth found to be normal, showed breech presentation. Interval growth scan was done at 36 weeks and found to have breech presentation, no history of bleeding, leaking PV, perceives fetal movements well, past medical history, no history of diabetes, hypertension, tuberculosis, bronchial asthma, heart disease or epilepsy, past surgical history, no history of surgeries in the past, personal history, normal bladder and bowel habits, normal sleep and appetite, no history of substance abuse, family history, nil significant history. General examination, height 152 centimeters, pre-pregnancy weight 64 kgs, BMI 27.35, weight gain in pregnancy is 11 kg, patient is moderately nourished and moderately built, no pallor, no pedal edema, thyroid and breast normal, vitals, temperature afebrile, pulse rate 88 beats per minute, respiratory rate 16 per minute, blood pressure 110/70 millimeters of mercury, in right upper limb in sitting position. Systemic examination, CVS S1 S2 plus, RS normal vesicular breath sounds heard, CNS no focal neurological deficit. Abdomen examination, on inspection abdomen is longitudinally distended, umbilicus flushed with the surface, linea nigra and stria gravidarum present, no scars, hernial orifices free. Palpation, on fundal grip, a hard and globular mass with difficulty in ballotment suggestive of head with extended legs noted, lateral grip, fetal back on left side and limb buds not so distinctly felt on the right side, pelvic grip, small conical mass suggestive of frank breech, 3/5 palpable, fetal heart rate was good, heard on the left side around the umbilicus. Pelvic examination, cervix was soft, posterior, 2 centimeters long, os admits 2 fingers, presenting part breech at brim, pelvis gynecoid. Summary, a booked 28-year-old G2P1L1 at 38 weeks gestation, previous normal vaginal delivery belonging to socio-economic class 2, EDD corresponding to the menstrual age with frank breech presentation and good FHS, admitted for safe confinement.
Now that we have a case of 38 weeks, second gravida, previous normal delivery in breech presentation with probably an average weight of the baby. Now, what do you think we should go on? We will discuss little later. But before that, Having said this, we should know what is the incidence of breech presentation in the present scenario. What is the incidence of breech presentation?
Sir, incidence of breech at 28 weeks is around 25%.
Okay.
At the same time, at 32 weeks, it comes down to 7%, and at term, it is around 3 to 4%. Sir.
Fine, fantastic. So we have seen that with the decreasing gestational age, we have an increasing incidence of breech presentation. So we have to put probably as prematurity as the first etiological factor for breech presentation. So let's not discuss etiology of breech presentation here. So having said that, the percentage is around 3 to 4% at term, and this patient belongs to term. Do we have types of breeches?
Yes, we classify breech presentation into two, complete and incomplete. Complete breech is that the baby is in the attitude of universal flexion. Incomplete we classify into three, frank, footling and knee presentation.
What are the three types? How do you want to say that?
Frank presentation, the baby's hip is fully flexed and the legs are fully extended.
Okay.
In case of knee presentation, the hip is fully the hip is fully extended and knee is flexed.
Okay.
And in case of footling, the hip and legs both are extended.
Fine. Okay. Now, can anybody tell us how the baby is going to be in the attitude of universal flexion and extension?
Yeah, universal flexion. The hips are flexed and the knees are also flexed.
Yes.
And incomplete breech, we have frank breech where the hips are extended and the knees are hips are flexed and the knees are extended.
Fine.
And footling presentation, we have hips are flexed and knees are partially flexed.
Okay.
And knee presentation, we have the hips at flexion and knees at extension.
Fine. So having known the different types of presentations, now do we do any other investigation to confirm that it is a breech, or we are very sure that it's going to be a breech presentation? We'll manage the case like this.
First, we clinically confirm the breech presentation.
Is that enough?
And then additional information is by our scan, USG.
So for confirmation of breech, clinical examination is enough, right? Yeah, it is enough. So, but does the ultrasound give us any other additional information other than the breech presentation?
Yes, sir. It gives information about position of the head,
Okay.
type of the breech,
Okay.
and then liquor volume,
Okay.
and placental position, and also the estimated fetal weight, and also the additional information if any anomaly is present in the fetus or any uterine anomalies also.
Okay. So fine. What anomalies in the baby do you expect?
Like anomalies like hydrocephalus,
Okay.
anencephaly,
Okay.
any cystic hygroma or mass in the neck.
Okay.
Yeah.
And any tumors of the uterus will be able to say sometimes.
Pelvic tumors.
Fine. So sometimes we'll be able to say, sometimes it may not be because it is in term and it can pregnancy can mask. So these are the additional information of which the ultrasound, and it is mandatory that we do an ultrasound for this lady.
Yes.
So now assuming that the baby's weight is 2.8 kg and the liquor volume is normal, maybe 10-11, and the baby is in complete breech or whatever type of breech. So now frank breech. So let's assume it's a frank breech on an ultrasound, and she's somewhere around 38 weeks. Now, do we have any management options for this particular patient, or what do you want to do with this lady?
There are three lines of management. One is external cephalic version.
Okay.
The second one is assisted vaginal delivery and cesarean section.
Okay. Fine. So now, having said that, you've got three. How do you want to choose between the three modes of management for this particular lady?
So the mode of management will depend on, we have to also include the patient in the decision making.
Okay.
So she is already a second gravida, meaning that she's already gone through the trial of labor.
Okay.
And the pelvis seems to be reasonably adequate, and this looks like an average size baby, and in according to the hospital protocols, the various managements can be discussed, which being, like he said, external cephalic version or assisted vaginal delivery or a cesarean section.
Fine. So now if it's going to be an ECV and the patient says, why don't you turn the baby and then allow it to be a cephalic presentation, how do you want to do, and what are the pros, cons and merits and demerits of each method? So what do you want to say about external cephalic version?
Yes. External cephalic version is usually attempted after 36 weeks of gestation, because if at all a need arises for a cesarean section, we reduce the complications of iatrogenic preterm delivery. The prerequisites are involving the adequate amount of amniotic fluid, a proper pelvic examination to rule out CPD and contracted pelvis.
Contracted pelvis.
And any placenta localization.
Okay.
We
But
have
done by ultrasound.
Yeah.
Okay.
After making sure of all these parameters, we make the patient lie in a supine position, asking her to after voiding, and we give a dorsal in a dorsal position with the leg raised at a 15-degree angle, and then we palpate. We keep our left hand on the fundus and the right hand locating the podalic end, and maintaining the attitude of flexion. We gradually guide the podalic end towards a transverse position, and monitoring efforts throughout the process. After coming to the transverse position, we switch over our hands so that there's no crossing over, and then we bring the head end towards the lower side and the podalic end to the fundus.
Fine.
After this, we check the fetal heart rate, and we periodic NSTs are to be done to rule out the fetal distress.
Having said that, the ECV is done this way and hopefully it is successful. But what do you think is the percentage of success in an ECV?
60 to 65% of ECV.
So that only means 30-35% of breaches come back to their original position. Can we do some splinting or put a rubber sheet and tie on the mother? All that has been tried, but there's no evidence to say that if it's going to turn, it's going to turn back, right? How many times can we attempt a version? So we've done a version, it comes back to its breech presentation. Can we repeat a version? There are enough evidences to say you can repeat it, provided you're quite confident to. There are some people who say you can't repeat a version.
We can ask the patient to come back after a week and probably try again.
If she's over 36 weeks, right? So now, having said that, you have any indications, any contraindications to do an external cephalic version?
Inadequate liquor.
Okay.
And placenta previous.
Okay.
And macrosomic babies.
Fine.
And any contracted pelvis.
Contracted pelvis. Previous section, previous myomectomy, probably. So these are all contraindications to do a external cephalic version. So when we do an external cephalic version and we say that it has failed, we will attempt, may not attempt. But in the modern obstetrics, we have seen an increasing rise of C-section. Is there a role for vaginal delivery at all if it is going to be a breech delivery? Is the question which I'm going to ask you now and you can answer. So do we have a chance for a vaginal breech delivery in this particular case?
Yes, sir. The vaginal delivery of breech can be of 3 types. There can either be a spontaneous vaginal delivery wherein the patient is coming in full-blown active labor and the pelvis is quite adequate. We will allow her for a spontaneous vaginal delivery. Or there could be an assisted breech vaginal delivery or a total breech extraction in case we need to. There is no option for cesarean section, whereas we are in a setting where we don't have enough facilities to do a cesarean section. We could go for a total breech extraction.
So you're not against a breech delivery at all?
No.
Fine. So that's fantastic. So if you want to do a assisted breech delivery, how would you do and what setup would you expect, and would you be able to demonstrate a assisted breech delivery?
Yes, sir. For an assisted breech delivery, first we have to confirm the fetal and the maternal well-being. So the average size baby with a good fetal heart rate and a maternal good adequate pelvis in the presence of an anesthetist, a good neonatologist and a skilled obstetrician, which is a very important prerequisite, we would attempt a vaginal breech delivery.
Would you be able to demonstrate an assisted breech delivery at all? So now you're going to demonstrate how we're going to deliver a breech.
Sir, commonly the engaging diameter of the breech would be a tuberous diameter, which is about 10 centimeter, and the most common position would be the left sacral anterior position. So I'm going to be demonstrating to you a frank breech assisted vaginal delivery in the left sacral anterior position.
Okay.
So the prerequisites for the delivery would be a fully dilated cervix with a ruptured membranes and a good adequate pelvis, presence of the neonatologist, like I said before, skilled obstetrician, and adequate facilities to do a cesarean section if at all the need arises. Okay. So once there is full dilatation of the cervix and the breech climbs on the perineum, I would follow the hands-off technique until the delivery of the buttocks.
Okay.
So once we should not go in for any unnecessary traction over the groin, which could cause even the deflection of the head, and there would be a delay. So once the buttocks delivers and it moves anteriorly and the legs come, this case being a frank breech, I would wait for the limbs to deliver, but in case the knees are not able to deliver, I would go in for the Pinard's maneuver and try to, in which I would put 2 fingers on, I would go laterally and try to abduct the thighs, and I would reach the popliteal fossa and flex the knees and try to bring it out.
Fine.
and I would repeat the same procedure on the other side. I would go laterally, abduct the thigh and reach the popliteal fossa, flex the knees and bring it out.
Fine. So legs are delivered.
Legs
Next.
are delivered. Now I would again follow my hands-off technique and wait for the baby to deliver with the maternal expulsive effects until the umbilicus is delivered.
Fine.
So once the umbilicus is delivered, we would preferably keep the baby in the anterior, sacro-anterior position. So once that happens and there is some descent, we would allow the breech to hang on itself, and we would also palpate for the presence of any cord below. If at all there is a cord, I would slightly move it away and leave it onto one side. I would not mess with it too much, and I would still leave for the breech to descend by its own. So once the umbilicus is delivered, and we would wait for the delivery of the hands up till only when we see the lower angle of the scapula.
Fine. So when you see the angle of the scapula, what do you do?
So once I see the angle of the scapula, next I would see if it is a flexed arm or an extended arm, which we would see from the angle of scapula itself. If the angle of scapula is in parallel with the vertebral column, it is a flexed arm. So if it is a flexed arm, I would still wait until the descent happens and till I see the axilla to deliver the arms. If at all the angle of scapula is showing there is some winging of scapula, I would presume it is an extended arm, and I would still wait for the axilla to deliver and then go in for any of the maneuvers to deliver the arms.
So if it is an extended arm, what do you want to do?
So once I would wait till the axilla is seen on either side, on one of the sides, and actually if it is spontaneous vaginal delivery, either of the arm can deliver first. But in case of an extended arm, we would go for the Lovset maneuver, in which the posterior arm being at the lower point than the sacral promontory, whereas in the anterior arm would be above the pubic symphysis. So what we would do in the Lovset maneuver is we would turn the fetus 180 degrees to bring the posterior shoulder under the pubic symphysis, so that it would free and we can flex the arm and deliver it.
Okay.
So we could put two fingers into the put 2 fingers into the vagina, reach the elbow, flex the arms and pull it out.
Okay.
And once the posterior arm is freed, I would again rotate the baby 180 degrees to bring the anterior shoulder back under the pubic symphysis. Put 2 fingers across along the upper arm, reach the elbow, flex the arms and deliver it.
Fine.
So after this is done, I would again put the baby in the sacro-anterior position and wait with the breech towel.
What are you using the breech towel for?
To prevent, we would cover the baby with the breech towel till the nape of the neck is seen, to prevent premature respiration of the baby and any aspiration and causing asphyxia for the baby.
Plus you will have a better hold of the baby as well. Fine. So now how do you want to deliver the aftercoming head?
So till the shoulders, the baby would deliver easily, but whereas the delivery of the aftercoming head is where a lot of problems arise. So we would wait again with the hands-off technique until the nape of the neck is seen, and the baby is allowed to hang down by itself. But with the monitoring and intermittent USG monitoring of the heart of the FH also should be done. And once the nape of the neck is visible, there are 2 methods which we could use to deliver the baby. One is the Marshall-Burns technique, in which we would hold the one finger between the 2 ankles and one and 2 fingers on either side of the ankles. We would hold and we would form a wide arc around the abdomen of the mother, and then the baby would be born by first chin first, then the mouth, then the brow vertex, followed by the occiput would be delivered.
Fantastic.
So this is a Marshall-Burns technique.
Fine. What is the MSV technique?
So what we do is the modified MSV technique, in which the baby is allowed to hang on the left forearm, whereas your index and middle finger is placed on the both malar prominences, and the right arm of the surgeon is the index finger is placed on index and ring finger is placed on either side of the shoulder, and the middle finger is placed on the occiput, and the left arm will cause the flexion, will cause flexion, and the right arm will also cause flexion of the head, and you will deliver the head with upward movement of the left arm keeping the flexion in situ, and the baby will be delivered.
Okay, fantastic. So what do you think will be the work of the assistant, if at all they have an assistant to deliver the breech?
So in case even after these two methods we are not able to deliver the baby, we might have to deliver the aftercoming head using a forceps, where we would need an assistant to hold the baby with a towel and hold the baby across. And also in both the techniques when we are doing, I need an assistant to give perineal support to prevent complete perineal tears or extensions of the laceration.
That is for an assistant at the vaginal end. You may have to have an
Also,
assistant.
We will also have an assistant to
suprapubic.
give suprapubic pressure to maintain the flexion of the...
Fine. So this is how we've delivered. So having said that, if you're used to delivering by forceps, so what type of forceps will you use?
So we could use a Piper's forceps, but what we use in our setup is a long-handled forceps.
Anything.
Any
So
long-handled forceps which has a long shank to support the baby can be used.
Fine. There are enough people who don't do Marshall Burns or the MSV technique, and they put a forceps straight away, and there are proponents who will do any one of the three. So that's fine. All three methods have equivalent results of delivery of the baby, and the hypoxia rates are also equivalent in all the three babies. Fine. So now, having said this, it looks very easy when you're demonstrating with the dummy and mannequin. But then if it's going to be a live baby, you think are there going to be any complications on this breech delivery which we're worried about and threatened about?
Complication is there for both the baby and the mother. For the mother, it can be a genital tract laceration, perineal tear, obstructed labor, or uterine rupture. For the baby, it can be birth injuries like clavicular fracture, humerus and femur fracture, brachial plexus injury, or it can be a birth asphyxia secondary to cord prolapse and cord compression, or it can be a damage to the head like a fracture and intracranial hemorrhage.
Having said that, are there any clear-cut indications for a cesarean section in a breech presentation? I don't want you to answer saying for a fetal distress I will do C-section. For a fetal distress, even if it's cephalic, you will do C-section. Breech per se are the clear-cut indications where you will do a C-section.
Yes, sir. Clear-cut indications like placenta previa,
Okay.
any pelvic tumors, these
Okay.
two will preclude the normal vaginal delivery.
Okay.
And then also estimated fetal big baby, like more than 4 or 4.5 kg
Okay.
kind of babies. And then even
Contracted
pelvis,
Okay.
history of CPD or anything. And then
So breech per se, the problems would be knee presentation. I would do a cesarean section.
Fantastic.
If there is a nuchal arm or a hyper extended head with the stargaze fetus, which would be confirmed on a USG, I would go for a cesarean section right away.
Fine. So all these are indications for a cesarean section in a breech per se. So now we have seen when will we do a vaginal delivery, when we will do a C-section, when we will do an external cephalic version, we've said. So now can you say on which patient will you choose to do a vaginal breech delivery?
If the patient comes in full-blown labor,
Fine.
if I would do a thing, or if she's a second gravida, like in this case, who's already had a trial of labor with an adequate pelvis and good height, I would give her the possibility of normal vaginal delivery. And also, if on per vaginal examination of a term patient, if she has a good Bishop score and good pelvis, we would allow her to go in for spontaneous labor.
Fine. So having said all these things, there has been enough confusions, and we've also said that we have 3 modalities of treatment for this particular lady. What is the evidence? Do we have any trials which we say that we should do vaginal delivery, we should do C-section, etc. So do we have any trials to support saying that this is the option which is probably the best?
yes, sir. For term breech fetus, they did a study called term breech trial, HANA trial. Collaborative study was done in multi-centers, around 121 centers in 28 hospitals all over. They studied, the inclusion criteria was only the single-ton breech pregnancy ladies. So amongst that, they had planned, it was a randomized control study. So they took a number of patients, 1,141. They planned it for cesarean section and 1,042 for the planned vaginal deliveries. And one group who were planned for cesarean section, 90% ended up in cesarean section only. And the one who were planned for planned vaginal delivery, only the 57% ended up in normal vaginal delivery.
Okay.
And they looked up for the neonatal mortality and morbidities, and also the maternal morbidity, any complications throughout. So they came to a conclusion that neonatal morbidity and mortality or complications long term, it was comparatively more in planned vaginal deliveries rather than the cesarean sections. So there are some disadvantages of this study also. Though it was done in various centers all throughout, the entry protocols were different. They have somewhat 2 or 3 twin pregnancies were considered.
Though it was singleton,
Though
was the
the
entry point.
inclusion criteria was singleton, and so
They included only primigravidas,
Yes.
which was another problem, and they followed up the patients only until 6 weeks.
Okay.
So the long-term neurological sequel, later studies which were done did not show much of a significance in the perinatal outcome.
Fine. So, but what happened to the HANAS trial somewhere around the year 2000 when it got published? It became very popular. So, because it became very why did it become popular? It got published in the Lancet. So, when the Lancet published it in the year 2000, HANAS trial, what happened was the rise of cesarean sections it really went up because of the HANAS trial, and so HANAS trial was wide open all over, and we all took the nicer points of the HANAS trial, leaving the worst points. What happened in the HANAS trial, as she said, there were negative points of the HANAS trial also, and in most of the centers the delivery of vaginal breech was not conducted by the senior most obstetrician or so experienced obstetrician. So the level of expertise was different amongst different hospitals. It was not uniform. That's a big flaw. The next flaw of the HANAS trial was that lot of places had only 5 or 6 entries through the year because it is multicentric. So out of that, the complications, if you put in, it is very less and in the vaginal delivery. So we can't take that as usage of, we couldn't use them for the general population. So these were all the flaws of the HANAS trial. So, but what happened was, because the Lancet published it, fast forward and published it, HANAS trial became popular and everybody started doing C-section for a breech material, whether it's a primary, multigravida, second gravida, third gravida, whatever. So the incidence of C-section did go up when the HANAS trial came in, and there was some time when we had paucity of literature to say after the HANAS trial, because it was probably the panacea for deliveries, and so we did a lot of sections around that time. Do we have any evidence to say that there are pitfalls of the HANAS trial, and we have any other trial which said we can do a vaginal delivery also?
Yes, a trial called Primoda trial, which is the presentation and mode of delivery, what it says, Primoda. It was studied in France, the French study. It was an observational study done. Around more than 8,000 women were taken in the group study, and around 2,500 ended up in the planned vaginal deliveries. And the outcome of this study showed that though the patient end up in a planned vaginal delivery or the C-section, the neonatal mortality or morbidity or complications were equal enough. Nothing that planned C-section has a lesser consequences compared to vaginal delivery.
Fine. So the Primoda Goffin trial came afterwards and said that, oh, you could do a vaginal delivery also. That was the practice in your hospital. You could go, and they said safety of the vaginal breech delivery was rejuvenated, if that's what I should say. So they said you could do a vaginal breech delivery also. But then when we do vaginal breech delivery, we didn't know, do we have any predictors, or do we have any scoring, or do we have anything, oh, this patient will have a vaginal delivery? Can we just do a little bit of scoring and say, apart from your clinical examination and apart from your ultrasound, do we have some crystal form of saying, can we use some system?
There is a Zettuccini-Andros scoring for a breech, which includes the gestational age. Their scoring is for 0, 1 and 2 points. So gestational age less than 37 weeks would have a 0 point, 38 weeks would have 1 point, and 39 weeks would have 2 points. And the estimated fetal weight in pounds. So more than 8 pounds would have a score of 0, 7 to 8 pounds would have a score of 1, and less than 7 pounds would have a score of 2. And then there would be the dilatation of the cervix, which would be 2, 3 and 4 in the rising thing, and the station of the cervix. The lesser the station, like -1 station would have, -1 would have a score of 2, and -2 would have a score of 1, and -3 would have a score of 0. And the parity, if they're multiparida, or if they're primigravida or second gravida. So a score of 0 to 4 would indicate the possibility of being ended up in a cesarean section, whereas score more than 4 is favorable for vaginal delivery.
Fine. But having said that, there is a Zettuccini-Andros scoring. We don't use it very often in clinical practice. Then came the Weston-Moore scoring. We're not using it in clinical practice also, because of the clinical examination and the expertise of the obstetrician, 1, and 2 for the ultrasounds. So because of the availability of ultrasounds very easily, so we could estimate the fetal weight, etc. But of course, we could include Zettuccini-Andros scoring as well. So putting all that into consideration, why do you think still the vaginal breech delivery is not very popular? After having said the Zatuchini underscoring you could use the ultrasound. There are enough methods to deliver vaginally and everything very safe. Why do you think the vaginal delivery is still not popular? I think it is mostly the fear amongst the obstetricians of whatever litigation or after coming head, etc. That is the fear. So how do you think can we take off the fear and promote a vaginal delivery for a lady who comes to you in breech presentation?
Sir, we would first, for all training candidates like us, we would take the help of skilled obstetricians and learn on mannequins and simulators.
Okay.
So to keep the art of vaginal delivery in breech going, we should, in case if a patient comes in labor in breech, we would call for a skilled obstetrician to be around, and we would conduct the delivery. And also in mannequins and simulators, we would do that.
Fine. So having said that, can we give off the art of breech delivery by doing away with the cesarean section is a question which we have to ask for ourselves. We can't do that because there are conditions when you'll have to do a breech delivery. Definitely you can't avoid. For example, when a breech comes in labor, you can't push the baby inside and do a C-section. 2, when it's a preterm breech. 3, when you have a IUD and a breech in labor, we can't do a C-section for just because it's a breech presentation. So these are conditions where you can't avoid or negate using a vaginal breech delivery. But please understand, when you do a breech delivery, the incision is just 10 centimeters above, incision is 10 centimeters below. I mean the vagina and the pelvis is 10 centimeters. So you have to deliver only within 10 centimeters up or below. Only thing you're delivering at a higher level, but whatever, even at cesarean section, you may have to do the same maneuvers as what you did on a vaginal breech delivery. And so we can't negate or close off vaginal breech delivery as far as breech presentations are concerned. ECV can be an option in select cases, easy option as well. So the moral of the story today is, please don't think that C-section is the answer for everything, and C-section is not the only choice for a breech delivery. And especially in centers where we have tertiary care units, I'm sure breech delivery of assisted breech delivery in a vaginal mode is probably an encouraging option, followed by an ECV, and cesarean section should probably be the last of the options unless you have other indications complicating a cesarean delivery. So I hope this breach of faith will go off after this discussion of breech delivery, and we promote more and more of breech delivery vaginally. Do you think the vaginal breech delivery coming down and C-section rates have gone up has had any impact in the classification of?
Yes, sir. In the Robson's classification, there is a increase in the. There is a inclusion of breech deliveries as one of the indications for cesarean
So we have gone so far to say that we've had a classification as such for a breech delivery to say what is the percentage of breech which increases the C-section rate. So putting all that to considerations, we will probably promote vaginal breech delivery, and that's the message which we want to give across this presentation. And thank you very much for being with us.